So now I get the pleasure of introducing our keynote this year, Brock Slabach, who is the Chief Operations Officer at the National Rural Health Association. He joined NRHA in 2008, and he has the administrative responsibility for all the areas of member service, including membership communications, meeting, exhibitions, all those types of wonderful things, and all the staff. He was a rural health administrator for more than 21 years and has served on the board of at the National Rural Health Association and the Regional Policy Board for the American Hospital Association. Brock specializes in rural health system development that encompasses population health and the varied payment programs providing rural providers into moving rural providers into value-based purchasing models. He is a member of the National Quality Forms Measures Application Partnership, Hospital, and Rural Health Work Group, and serves on the board of directors of the Accreditation Commission for Healthcare. Brock is the 2015 recipient of the Calico Quality Leadership Award of the National Rural Health Resource Center and received the American Society of Healthcare Pharmacists Board of Directors Award of Honor for 2018. He has earned his Master's of Public Health degree in Health Administration from the University of Oklahoma and is also a fellow in the American College of Healthcare Executives. And I have to say he's also a good friend and partner to have. So Brock, I will hand the reins over to you at this point.
Well, thank you, Melissa. And thank you to everyone on the call today who's going to share in this time that we have to talk about rural health. Melissa's done a great job at the Missouri Rural Health Association, working with the Hospital Association and the Primary Care Association and all of the other groups that are working so hard to propel rural health care in our state. I consider this to be home, even though I actually live and work in Kansas. NRHA has an office in Kansas City, Missouri. So we're I consider myself to be at home today. So thank you so much for allowing me to come and share with you. I am only sorry that we're not on the lake and enjoying the facilities there in Camdenton. I was looking forward to spending at least a day there and being able to hang out with you guys around the pool or on the lake or wherever we would have gathered. So I'll talk a little bit more later in my presentation about the problems we're having with the coronavirus at the moment and how this is impacting providers nationally. So anyway, thank you all for your patience as we move through the pandemic and flipping to a virtual conference. I know it's not easy, and Melissa and her team have done a great job to make that happen. Our mission at NRHA is to provide leadership on rural health issues, and we are a membership organization with members all over the country. And I want to just take a moment to thank everyone on this call who's a member of the National Rural Health Association. Here's a distribution of our membership, and we have a lot of dots in Missouri. And so we're just really thankful for your participation in making your voice louder. Here's a list of some of our meetings upcoming, 2021 and 22. We just made the decision yesterday to move our September Rural Health Clinic and Critical Access Hospital Conference to the virtual format. So like you all, we projected what was going to be happening with the coronavirus between now and the time of our meeting and felt it was too risky to gather in person. So we're now in the process of moving everything to the virtual environment. We're hopeful we'll be able to meet on site in Washington, D.C. next February, 8 to 10 for Policy Institute. Mark that down on your calendars because this is one of our signature policy meeting where we get to talk to the members of Congress and the administration to be able to advance our issues in the halls of Congress and in the executive branch. For our annual conference and Rural Hospital Innovation Summit, we'll be in Albuquerque next year. So May 10 to 13. So mark that down on your calendar. It's a great opportunity to get to see a little bit of the Southwest and the southwestern part of our United States. It's beautiful there. I would encourage anyone that's not been there. It's really worthwhile. So pivoting into the core of my presentation, and I think we have ample time today. So if there's a question, just put it into the chat box. And Melissa, if you don't mind, or somebody else to monitor them as we move along, or you can wait till the end. So either way is fine with me. If you're like me, sometimes something will hit my head in a question, but then by the time we get to the end, I forget. So if that's the case, then feel free to just raise your hand to speak or to chat in a question. We have unprecedented challenges that are existing right now in the rural safety net. We were already stretched to the limits before the pandemic with the problems of comorbidities and mortality that was challenging our rural communities. Then the pandemic hit, and it just served to increase the levels of complexity for providing care and taking care of the populations that we serve. The impact, as I said, of the pandemic has been certainly ravishing all parts of the United States, and Missouri has been really hit hard. And I'll talk a little bit about that in a little bit in terms of the number of infections and the impact on our hospitals and clinics. NRHA has participated in an unprecedented amount of advocacy and funding wins, and I'll talk a little bit about some of those over the last year since the pandemic has started. But I'll tell you, there's been a flow of money coming from Washington that has been extremely valuable to all of the individuals on this call. And it's just been an extremely important element of participation in being able to get as many resources as possible for you all to continue your work. At the same time we had the pandemic brewing, we had racial justice and health inequality issues that were just bubbling up all over our country. We had the unfortunate demise of George Floyd up in Minneapolis, and then that unleashed last summer in 2020 of just a lot of discomfort by so many in response to that horrible action that took place there. And so we've been dealing with that and looking at the exposure of systemic racism and health equity issues all over our country, and how that then looks and translates into health equity as an issue for rural populations, and making sure that we advocate for that as well. Then last year we had the election of Joe Biden as our president, the 45th president. And you can see here, we installed a new Congress in January of this year. And then President Biden took office in January. And so we've been adapting to a new administration in the halls of Congress. And then at the same time, through all of this, innovation is continuing. So we have a lot of issues going on around our country related to new models that are being tried and tested, such as the CHART model, the community transformation track that's part of that. And then we have other models like, for example, what's the Pennsylvania rural health model up in the state of Pennsylvania. So I'm going to talk today about the rural landscape. Where are we? What are some of the issues that you all are confronting, and what we're doing as a collective, to solve some of these problems? I've already mentioned the rural health safety net. Whenever you're talking to members of Congress, to policy makers in Jeff City, it's helpful to remember the elements of the why of what we do. We do what we do in our rural communities because we love the work. We love the people that we serve. Many times, as I grew up in a rural area in Kansas, this is family. These are friends. These are people that I've known for generations. But these populations are vulnerable. We're facing systemic workforce shortages, and these are just intractable. Scattered populations with inherent access to care. When you have large areas of land and few people, it makes it difficult to organize services efficiently. Inadequate Medicare and Medicaid reimbursement in terms of coverage and reimbursement. I've been having lots of conversations with commercial insurance companies lately, and I've been talking to them about the historic systemic inequities in reimbursement that have been and underfunding that have impacted rural providers for a long time. And we've got to do a lot to overcome some of those systemic failures over the last 20 or 30 years when it comes to rural populations. And then the lack of Medicaid expansion and high uninsured population. And finally, the state of Missouri has expanded Medicaid officially, and individuals are being enrolled in that program as we speak. And it's been a long, arduous journey. I want to tip my hat to all of the organizations on this call, the Primary Care Association, the Hospital Association, the Rural Health Association, and all of the others that collectively joined their voices together on behalf of rural populations and urban ones as well, and got the Medicaid expansion through and actually implemented in the state. And then I'll talk a little bit today about rural provider closures. We have still, unfortunately, we're tracking that and a little bit about what that means for our healthcare safety net. So talking about rural hospital closures, we've had 138 as of this month, number of hospitals closed. Tennessee and Texas still lead the pack in terms of the sheer number of hospitals. Missouri happens to be in the top number of 5 to 8 hospitals that have closed in our state. And this is, of course, a problem for our rural communities in terms of care. Vulnerable hospitals, these are hospitals that are what we call at risk for closure. This is a measure that our friends at Chartis Center for Rural Health have done, and they've distributed those 453 hospitals in terms of the percentage of the number of hospitals in that state that are at risk in terms of this issue. So you can see that, unfortunately, Missouri has a large number, high percentage, 31 to 40% of its hospitals that are at risk for closure, almost equal to Tennessee, Mississippi, Texas. So we see that there are challenges in our state, and these are certainly things that we are very mindful of and keen to try to solve in not only Missouri, but nationwide. Now, I would like to think that over time, Medicaid expansion will help to solve some of this problems of rural hospital closures in our state, and I think this is a really important thing that's on the horizon that could be of some help. But by contrast, states like Kansas and Texas and Mississippi and Alabama have not expanded Medicaid, and they'll probably continue to see some of these problems continue. Rural populations disparities. When we look at the levels of populations that are at risk, and then we correlate that with the hospitals and clinics that are at risk, we see that the darker colored states here have higher uninsured individuals within those states. And again, that contributes directly to the lack of ability of those facilities to operate effectively. Not only, these are FQHCs, RHCs, critical access hospitals, PPS hospitals. This uninsured problem impacts all providers in rural parts of the country. Here's another way of looking at health disparities and where the metrics are in terms of some of the key ones that we look at. We usually say that rural populations, and you've heard it over and over, are older, poorer, and sicker. This graph here shows the number and the lopsided view of those over 65 in our rural communities. Premature death in rural areas far outpaces that of premature deaths in our urban parts of the country. And then uninsured children. Those are a vulnerable group of individuals that are really needing to have an address. The needs for insurance there are quite high. But when we look at the inverse in terms of the people that are there in rural communities to be able to take care of these vulnerable populations, you'll see we're just inverted. So access to primary care and access to mental health are two areas where we have a much lower number of professionals as a percentile ranking than we do in our urban counterparts. And then not on this graph, but would be equally important would be oral health. And the oral health availability in rural communities is extremely, extremely problematic. So all of these things combine to have a convergence of pressure points that impact all of the facilities that are represented in the attendance for this meeting, whether you're in a clinic, a social service agency, a nursing home, a long-term care facility of other types, hospitals, federally qualified health centers. All of these issues are converging to create really a fragile safety net that we have to pay a lot of attention to. So obviously, if you've been like Rumpelstiltskin and asleep for the last 20 years, then you probably don't know that we're in the middle of a pandemic, and unfortunately it's continuing. But I think this is an important discussion, not only because most of us or all of us on this call are public health professionals, but because this is impacting clinically so much of our healthcare system currently. So as of last week, August 1st to 7, here is a map of the new infection rates, the incidence rates of COVID for the week of August 1st and 7th. And you can see here that we have it distributed in this map from the Daily Yonder that they do so well putting together on a biweekly basis. If you are in a light green color, that means you're in a non-metro rural with a caseload of 100 cases or less per 100,000. So look up in South Dakota, North Dakota, Minnesota, you go up into the northeastern part of our country, into New England, you can see that we have large swaths of green or light loads of COVID in terms of new cases. Now, when you go to the red color and the black color, the dark red, those are where we have cases that are higher than that number of the green. So non-metro rural, 100 to 500 cases per 100,000. You can see almost all of the counties in the state of Missouri are colored in that darker red according to this the data from August 7th. Then the cases of 500 cases per 100,000, this is a rate that's very high relatively. We have a number of counties in Missouri that are also impacted with a very high case rate of new cases being diagnosed of COVID. So this is an interesting map. If you look at the southern states, you can see that we have a large number of very deep red and red cases of COVID incident rates. I threw up for you just a comparison of where we were in June of this year. Just look back in June where the case rates were in terms of new cases being discovered. And you can see that the Delta variant of the coronavirus has really just spread like wildfire all over the United States. And it seems like in 2 months' time, it went from this to this. And it's a pretty stark contrast for sure. So when we look at the COVID cases, rural versus urban on the number of cases, I just got this from the CDC yesterday. So this goes all the way through August 14th. You can see not only do we have cases, new cases trending upward in general, we're now at the same level we were at in February of this year in new cases, which is pretty scary when you think about where we were last winter in terms of infection rates. Now look at the number of cases in rural parts of the country. We're outpacing death rates starting to correlate differently between rural and urban. So the green line is the rural line and the purple line is the urban. We're starting to see death rates trend up. This is consistent with what we saw in the winter in the third phase of the in the third surge. The interesting thing is that the death rates are lagging indicators. So you're looking at 2 to 3 weeks post infection when you'll start to see the death rate starting to increase. But you're starting to see the rate accelerating in rural communities, which is extremely concerning and something that we are watching very closely as a matter of policy and advocacy on your behalf. The CDC releases about twice a month their projections of where the COVID infection new cases will go in terms of numbers. And you can see on the left graph all of the metrics that are produced by different agencies and their modeling as to where we could go in the future in terms of, well, by September, in terms of COVID infections nationwide. And then CDC takes the same information and puts it into their probability graphic. And so much like hurricane predictions in terms of where the hurricane will go, you can see that red line is the projection, probably going to about 1.5 million new cases by September 1st. And as you know, with this disease and with the R0 of about 6 to 7 for the Delta variant of this virus, we could have by the middle of September, by the end of September, we could be seeing rates of COVID cases nationwide that look like what we had in the winter of this year. Now, I'm hoping that doesn't happen, and I certainly am not hopeful at all about that. I think that it's just realistic to expect that this next surge, because this is exponential growth in terms of this virus. Now, one antidote for the spread and way we can immediately stop at least the rapid fire spread of this disease is vaccination. And so that's why NRHA has been actively involved in programming to see how we can increase the rates of vaccination for people living in all areas of the country, but more specifically rural areas. So here's a map, just a very general map of COVID-19 vaccinations in rural as of July 15th. And you can see the darker the color represents a higher percentage of individuals in that state that have been vaccinated. So if you look at the state of Missouri, you'll see that we're trending lower on the coloration of the graphic in terms of the number of people in the state vaccinated. This is something that if we were to increase vaccination rates, would definitely stem some of the increases in the number of transmissions and infections statewide. So here is the vaccination rates in the United States as of yesterday, posted in the New York Times. This is fortunately a map by county, and you can see in Missouri, the lighter green means that you'll be in the 30% or less color in terms of the percentage of individuals in that county that's vaccinated. So if you go to your south and eastern parts of the state of Missouri, you'll see a large number of counties in that block that have 30% or less of their populations eligible for vaccination actually having shots in their arm. This is very low. Right now, the national average of individuals that are fully vaccinated is 51%. And so these are very stunning numbers. And it is not surprising when you correlate this graphic with this one, you'll see a definite correlation between those green parts of the country where they're having low rates of spread and this and where you're having high rates of spread is where there are low rates of vaccination. So I think this is evidence of what we're seeing and why this is so important. When we look at rural versus urban vaccine rates, you'll see, now this is as of July 15th, but I think the trending is still here. There's a 10.7% difference between metro or urban and rural rates of vaccination. And so this has been really stemming or indicating CDC has been spending a lot of time trying to figure out how to increase the rates of vaccination in rural populations. So part of that effort has been through a lot of money being distributed to rural health clinics, federally qualified health centers, fee-for-service clinics, hospitals, to make sure that you have the resources to be able to extend to your communities access to the vaccine. We're seeing that there's a lot of trending about where the best places are for vaccination. Obviously, where the local individual, the practitioner, has a very high amount of influence on whether someone is vaccinated or not. So the time that you take in your clinic to share information and actually get that shot in the arm is very valuable, because we've seen and anecdotally have heard a lot of evidence that that works. You want to get them quickly, because once they leave the clinic, then they may not be back. So it's important to have the vaccine available and ready to give. But these are the grant programs that have been implemented over the last 6 months or so, 4 or 5 months since the vaccine has actually been widely available to the general public. As I said, the important ways to enhance vaccine confidence is to share the facts. Actually, another helpful way to talk about it is how you can protect local businesses. This is an economic issue. No one likes to wear masks. No one wants to stay home in lockdown. And that only serves to hurt the economy. And so the economic issues are important. And then lastly, protecting yourself. This is obviously an important feature that, obviously you want to avoid hospitalization and death. NRHA has produced a COVID-19 vaccine talking points. And this, incidentally, this presentation, all of the underlined text like you see here are linkable. They're actually have links. And when I'm finished with this, today, I'll share with Melissa the file, and this can be distributed, and then you can link directly to these resources from this PowerPoint presentation. So our COVID outreach toolkit has basically the objectives of promoting the benefits of COVID-19 vaccine. We want to increase the rural residents' confidence in the vaccine and empower rural leadership from 3 key sectors to support vaccination activities. We look at the stakeholders for our outreach program to be obviously providers, hospitals, clinics, community health workers, public health officials. Another very strongly related area is rural faith leaders. So part of the work that we're doing now with Legato Healthcare Marketing Firm out of Wisconsin is developing advertising where you could actually put pictures of a local pastor or an imam or a rabbi into a document and then advertise locally why somebody of that type was vaccinated. That can often be very influential in a number of different communities. We're going to experiment with this in a community that has a meat packing plant where they have a large or high Somali population. And this is where, for example, the imam in the Islamic faith would be very useful in outreach to that community to help them understand the importance of getting vaccinated. And then don't underestimate the power of the rural agriculture leaders. We've seen examples of ranchers and farmers out west that have had vaccine programs where they brought in all of their workers, maybe 200 or 300 of them, and got them vaccinated all at once. These all are very important ways in which you can engage the extension service in your communities to assist in maybe getting vaccinations to your people. And then a feature of our toolkit is, as I've already mentioned, the talking points for community leaders. I've already mentioned the fillable templates, including op-eds, posters, public service announcements, social media, community guides and assessment, FAQs, frequently asked questions, and fact sheets, and then data. Some people want to know the data. They want to know what the risks is for them to take this particular vaccine. Here is a listing of all of the resources, again, online that we have available. And these are all hot links. I would encourage you to visit the We Can Do This COVID-19 website. Again, there's a lot of free resources there that you can just use for free in your marketing and public relations efforts. So now I'm going to pivot to an update from the administration. This is the executive branch of our government and all of the things that they've been doing of late. So the Biden team has gotten everybody in place. They are actually fully staffed almost in the healthcare sector, maybe just a couple of positions that are not now collected yet. But here is the listing. I'm pleased to say that Liz Fowler, the director of the CMS Center for Innovation, is going to be one of our keynote speakers at our RHC COM meeting next month. And so we're anxious to hear from Ms. Fowler on her view of rural innovation. And we think this is critically important going forward of where CMMI is going to position themselves in that conversation. Diana Espinoza is still the acting administrator of HRSA, so we've not gotten somebody permanently installed there. But I am pleased to say that Associate Torres Small has been confirmed as a USDA Undersecretary for Rural Development. And she's from New Mexico, serves a very rural district in that state. And we are excited to have her influence there in that agency to look at rural development, how we can use the tools of that agency to help rural facilities, clinics, and hospitals particularly meet their capital needs in a very stressful time. So we've been enduring a very strong time of regulatory releases. It's almost been a flood. We almost dread at NRHA a Friday afternoon because that's when they seem to like to release all of these lovely things for us. And of course, that means that it's the Friday evenings are spent reading regs rather than enjoying time with family and friends. We responded to the congressional request for information on the public option that was due on July 31st. There's a link there to the letter that we prepared and sent. This was in response to the Biden administration's preparation for the Build Back Better program. That's the infrastructure bill I'll talk about in just a second. And this was ways in which they can use the public option as a tool to expand coverage under the marketplace exchanges under the Affordable Care Act. The the FCHIP demo was extended in the Consolidated Appropriations Act from earlier this year. And in the IPPS rule, they got the FCHIP program extended by regulation. So that program will continue. That affects mostly hospitals and communities in Montana, North Dakota, and I think Idaho. The Rural Community Hospital, or the REACH program, was extended in the August 2 IPPS rule. This was where inpatient care was reimbursed at cost-based reimbursement for hospitals too big to be a critical access hospital. And then here were the different comments that the CMS was seeking on different rules that were released. The Home Health Prospective Payment System rule, those comments are due August 27th. The Physician Fee Schedule proposed rule, those comments will be due September 13th. And then the Hospital OPPS and the Ambulatory Surgery Center ASC rule, and it was released, and those will be due, comments will be due September 17th. In case there are any of you on the call that are interested in submitting comments to any of those issues. The Office of Personnel Management, or OPM, and Friends, I use that term loosely, released the requirements related to surprise billing. This was a couple of weeks ago, I think at least. And we've been going through those to see what onerous requirements that might be in that proposed rule that could be problematic for rural providers. The Office of Management and Budget released their notice of decision not to increase the minimum urban area population threshold. And they chose not to increase the minimum to 100,000 from 50,000. And NRHA had sent a letter to OMB expressing our sincere concern about that increase in the definition of a rural area. I know in the state of Missouri, it would have really made a good number of other counties that now are not rural, they would become rural if that policy had been enacted. And the concern there would be, well, two. One, the hospitals and clinics in those counties, they now want to be rural. And secondly, it could dilute a number of grant programs and eligibilities, for those that are existing in very rural communities by expanding the number of rural parts of the country. We submitted comment on the Occupational Safety and Health Administration's emergency temporary standard that were set to go into effect for hospitals. And we consider those to be extremely onerous and not at all helpful. And we said so in our comment letter. These were standards that were applied by OSHA that are about 10 to 15 months old in terms of science, and are inconsistent in many cases with even more current CDC and National Institutes of Health guidelines for the same thing. So obviously they need to get their act together in that regard. President Biden announced his executive order on promoting, my flywheel's getting crazy. On the transparency requirements that are now impacting all hospitals, including rural hospitals. Unfortunately, the CMS had released the proposed rule to adjust the penalties for non-compliance with transparency rules for bigger hospitals. So hospitals 30 beds or less will stay at the $300 per bed per month. If you're larger than 30 beds, then it goes up accordingly. And I think the maximum is $5,500 per bed per day. So for a larger hospital, the stakes have definitely increased in terms of the amount of the penalty. HHS announced immigrant populations can now access public benefits such as Medicaid. And that may not be as big a deal in Missouri as it may be, say, down in Texas, parts of the country that are on the border with Mexico. But I've heard around the country a number of immigrants without status have been seeking care in our clinics and in our hospitals, even in states like Kansas and Missouri. So this could be very useful in getting coverage for individuals that you might not have been able to get payment for. And then the United States Department of Agriculture released the Emergency Rural Health Care Program, which is a $500 million grant program for COVID-19 testing and vaccines, rural healthcare services, food assistance through food banks, and food distribution facilities. This is all meant for counties and areas of 20,000 or less. So if you are in a very rural community and you're providing services through a nonprofit or some other agency qualified under this program, you can apply for these grants. I have a link here to the, and this was just released last Thursday, by the way, so this is very new. And you can, there are 2 webinars. The link over each date is a registration link for each webinar to get more information on how to apply for those grants. There are 2 separate grants. One is specific to an institution, and it's in preparing for COVID-19 or working in some space for rural healthcare. The second element of the grant that you could apply to is networking and collaboration across the continuum. So there's 2 options for you to consider in this program, and I would highly encourage everyone on this call to take a look to see where your rural community could qualify to apply for this grant. So we are still in the time frame of worried about the provider relief funds that have been forwarded to hospitals, FQHCs, and rural health clinics since the beginning of the program back last March and May of 2020. Finally, HHS has released the reporting portal, and the first reporting period is going to be due September 30. So that's going to be very quickly upcoming. I would encourage all providers on the call to make sure that you're paying attention, looking at that reporting portal, getting your data together on how you'll be assembling it to be inserted into this particular format. HHS issued new provider relief frequently asked questions on July 15th, and those are linked to in this link that I have above. We have been advocating on your behalf with HRSA directly, Health Resources Services Administration, on getting flexibility in reporting of capital investment timeframes. Unfortunately, if you received your provider relief funds before June 30 of last year, you have a very short timeframe, which is already passed actually, which was July 1st. To spend your money for capital related expenditures. We think that's totally deficient and that needs to be extended. Clarity on the reporting of the depreciation cost on cost reports for cost-based services and how the allocation of the remaining dollars, as well as the $8.5 billion provided for in the American Rescue Plan that was passed in March. So we haven't seen any instructions on that either yet. I am encouraging everybody that's impacted or not by this to contact Blunt or Hawley, and I didn't change this for my presentation in last week, but Senators Bennett from Colorado and Kramer from Wyoming or Idaho, one of the two, they introduced this legislation, and I would encourage you to contact Blunt or Hawley or your representative from your congressional district and ask them to sign on to the Provider Relief Fund Deadline Extension Act. And I have the bill numbers here, but this is a law that would allow providers who receive PRF awards before June 30th of 2020 to have until at least the end of this year or until the end of the public health emergency to use their funds. So we're definitely working with Bennett and Kramer on this, and we think that this is an important entry that'll be very helpful to kind of bypass, if you will, HRSA on their way that they've been interpreting this particular piece of legislation. So what's going on in Congress? I mentioned earlier that COVID-19 relief legislation since basically March of last year has just been enormous. I'm not going to go over all of these acts, but these were the acts that were passed into law since March of last year, all related to coronavirus and coronavirus relief. So if you all feel exhausted, not from just the virus, which has been very exasperating to deal with, but also dealing with all of these laws, even though they're sending us a lot of new money, it is still very stressful to have to keep up with all the requirements that they all bring. And so this is just a review of everything that we've been able to take advantage of over the last 15, 16 months. The American Rescue Plan was passed in March of this year, and we're still just uncovering a lot of the issues that are common in that. And I have a listing here. I'm not going to go over all of these, but what I'm mostly excited about is the $1 billion appropriation for the National Health Service Corps and the Nurse Corps Repayment Program. We're hopeful that the Bureau of Healthcare Workforce and HRSA will get all of these monies flowing very quickly so that we can take advantage of some recruitment help to get professionals to rural areas. And then, of course, the $500 million, and I already mentioned the emergency grants for rural healthcare, that was appropriated, that was passed in the American Rescue Plan. USDA did a pretty good job of getting the guidance on that notice of opportunity funding out pretty quick. So I'll give them a lot of credit for that. Infrastructure. We've been having Infrastructure Week for the last 3 years. And so finally, a bill has passed out of the Senate. It was a bipartisan infrastructure bill. They had $65 billion for broadband and connectivity build out. There's a significant mention of rural in this piece, and we're very excited that the Senate, at least to this point, has agreed that broadband in rural communities is essential. No funding for hospital capital was included. We're very sorry to see that. We worked hard to try to get that in there. And in the bipartisan text is that Medicare sequestration continued for an additional year until 2031. We're very disappointed to see that. They were going, at the end of the public health emergency, allow sequestration to go back, which would mean everyone would take a 2% cut from their Medicare reimbursement. And not only that, they extended it as a pay for one more year to 2031. So in other words, in order to pay for the infrastructure bill, they added another year to the time in which sequestration would be applied. The Senate voted last Tuesday, August 10th, and passed it out of the Senate. It is now at the House of Representatives, and they are on recess. But Nancy Pelosi, the Speaker of the House, is going to be bringing the back on August 23rd. And on August 23rd, she's going to be asking them to take up this bill along with the Build Back Better program, which is the $3.5 trillion infrastructure bill that would be done through reconciliation. And I'll talk a little bit about that in a second. So the bipartisan framework for the hard infrastructure, what we're calling hard infrastructure, that's roads, bridges, airports. You know what I'm talking about there. This is a link to our request document that we sent to Congress as this bill was being considered. What is in there is improved broadband services in rural America. What did not make it in the Senate version was the capital funding for rural hospitals, rural facilities. And we were sorry that that was not in there. It's possible it could be included in the House version, but not likely. In the Build Back Better framework, which is the soft infrastructure, this is the bill that was $3.5 or is $3.5 trillion. We are requesting that in that what we want included in this bill is basically telehealth services in rural America by making CARES Act and the public health emergency provisions through waivers permanent. So this would mean for FQHCs and RHCs, we want to have it in legislation that after the end of the public health emergency, those allowances would continue into the future without obstruction. We want an investment in rural workforce. We want maternal health support. We are looking at the vast areas of the country that have no access to women's health services, most in this case, maternal health, and we need more support there. And then rural health clinic modernization. And we're still wanting to get rural health clinics back to cost-based reimbursement versus what they have now, which is for provider-based at least, the cap to the Medicare economic index amount each year. The appropriations process is fast and furious right now. This is the time of year they start putting together the appropriations bills. Labor, HHS, that's Labor, Health and Human Services, and Education, and the Ag bills have been passed out of the House. The Senate Appropriations Committee is in the process of marking up the Agriculture bill, and we expect the Labor, HHS, Education bill to be considered in the Senate following their August recess. And it's likely that the federal government will be operating on a continuing resolution, at least for some amount of time. If the debt ceiling is not increased as part of this reconciliation bill, there will be a need by September 30 to raise the debt ceiling, which could create another showdown in Washington regarding that whole issue and the potential closure of the government. Here are our requests for the programming and new money, essentially for the appropriations. We want more money to the technical assistance program in the agriculture bill. We requested $5 million. The House Appropriations Committee put in $2 million, and we think the Senate is going to at least match that. The Flex program granting. We requested $92.2 billion. The House Appropriations inserted $80. Telehealth, we requested $37.4, but look at there, the Health Appropriations Committee actually put in more than what we requested. So there you go. We undershot a little bit, it looks like. The RMOMS program, the Rural Maternity and Obstetrics Management Strategies program. It looks like that we got the appropriations set in the House, at least to what we requested. Rural Residency Planning and Development, $12.7 million. And then we've been advocating for the implementation of a new Centers for Disease Control Office of Rural Health. It's amazing now that there is not a Department of Rural Health in the Centers for Disease Control. And we feel that it's an important time that we have rural proofing being done on everything in that agency because it is so central to everything that we do in disease management is a very important part of everybody's work now, and we need that rural representation. The House Appropriations Committee did not agree with us on that, but we have strong support in the Senate, so we're hopeful that that'll get into the Senate bill. Kind of a recap here again, but some of the summary of our requests, which I've already talked about most of them. And then here is a link to all of our appropriations requests that we've made and a little bit of explanation about each. And then starting to wind up, here are some of our advocacy items. Rural hospital sustainability. Many of you are aware of the Rural Emergency Hospital that was passed in the Consolidated Appropriations Act in December of last year. CMS is writing the regulations for that new provider type. They are actually requesting information from the field. So there is an RFI out there from CMS to gain more information and input on how this needs to be done. NRHA is preparing to submit our letter in terms of what CMS needs to consider as part of that process. We'd like to see a reinstatement of necessary provider status for CAHs, particularly those small PPS hospitals that would like to convert to CAH, but because of their mileage issues are prevented from doing so. And that's a piece of legislation that we're following, that we'd like to see done. And then elimination of the 96-hour rule, the condition of payment rule for critical access hospitals. We're really anxious to see more money applied to rural physician education and basically looking at the Rural Physician Workforce Production Act. This allows for the expansion of residency training slots in family practice and primary care, in addition to establishing more sites of training for rural training tracks and getting money out there to be able to make those work well. Talked already about the continuation of telehealth flexibilities that were provided for in the public health emergency. And we would like to see those in law to continue past the end of, hopefully, when we end this pandemic. Behavioral health and substance use disorder assistance. One of the things that we know is that these services are terribly needed in rural communities. And there are a number of bills that are being looked at to address those issues that we are definitely supporting. And I've already mentioned rural health clinic modernization. We're supporting these bills that are out there in Congress right now, and I have the bill numbers by them. There may be more. If you know of one that you're supporting and think that we need to add to this list, please send it to me. But the Accountable Care in Rural America Act, HR 3746, assuring access to 340B drug pricing during the public health emergency. This is an extremely important bill to those PPS hospitals that may not, because of the pandemic and the decreased number of patients that they have, especially in the beginning, may not meet the required threshold to participate in 340B. So we need to get that adjusted by legislation to make that work. The Healthcare Workforce Resilience Act, another workforce bill that we're definitely supporting. The Rural Telehealth Act, which will, another bill that will extend the waivers that we have for telehealth past the public health emergency. I've already mentioned the Physician Shortage Reduction Act, the Rural America Health Corps Act, and then finally the Rural Hospital Support Act. So we encourage everyone to advocate with us, and certainly we appreciate all that you've done to propel our causes, both in Washington and in Jeff City. I would refer you to our legislative tracker. So on all the bills I just mentioned, or others that you may be following, this is a cool way to go in and look up the bill and actually see where it is in the hopper. Has it been passed out of committee? Has it been passed out of the House or the Senate? Is it awaiting a joint conference, or did it pass joint conference and be sent to the president's desk? You can look at the tracking of this on your own and be able to tell your constituents and the people that you're working with where a particular bill is in the process. We want to urge Congress to protect all rural providers. The safety net is fragile, and you all are such a valuable part of that, and we want to make sure that that continues into the future. Urge Congress to invest in rural healthcare infrastructure, and then basically invest in rural health in general. As I mentioned earlier, we have years and decades of systemic underfunding for our rural providers and programs. And we need, through a health equity lens, to be making sure we pay attention to those inequities and get that corrected. Congress is on recess through the August break, although the House is coming back sooner than they had thought. But your senators and congressmen are in their districts, so take an opportunity to have a local town hall. We have our NRHA Rural Roundup and our weekly publication, NRHA Today, These are links to sign up for those if you're not getting them currently. And then there's ways that you can engage with us online through Twitter, Facebook, or LinkedIn. And that's often a way that we will quickly alert people to what's going on in Washington and news that might be happening in a quick fashion. So with that, I want to thank you for your time today and for your patience going through a long list of detail and some of it not great news, but it's the reality that we need in order to be able to know the problems that we have to solve. So I know that collectively with everybody here on this line, I think that we've got a great start to solving some of these intractable problems and getting the resources you need to serve your communities. So thank you very much. And with that, I'll turn it back over to you, Melissa, and see if there are any questions or discussion. And